Okay, we're going to talk about medications for sleep, anxiety, depression, and mood disorder. Some of these medications can be used for multiple things, so that's part of the reason why we group them together. I wouldn't necessarily say that they all have similar action, but they all affect neurotransmitters in the brain at some point or another. And so that's kind of one of the reasons why we use them together. And some of the drugs are used for multiple reasons. So there's not always one category that they fit into. So the medications we're going to talk about will be antidepressants, multiple types of antidepressants such as the tricyclics, SSRIs, MAOIs, which are monoamine oxidase inhibitors, and then we even have atypical antidepressants. We're going to talk about benzodiazepines, barbiturates, non-benzo, non-barbiturates, and mood stabilizers. And most of these drugs are going to work by altering neurotransmitters, especially when we're talking about the antidepressants. And so they alter the levels of norepinephrine and serotonin, or they slow nerve activity in the brain, and this would be useful for inducing sleep or rest. If we activate the reticular activating system, which is responsible for sleep, and blocking dopamine receptors. I think we only have really one med that affects dopamine at all. So these are some of the things that we're going to talk about. Again, because they are working on altering levels of neurotransmitters, they're going to work in the synapses. This can be that they prevent a response traveling down the presynaptic neuron. It can prevent the neurotransmitter from being destroyed or being returned to the presynaptic neuron so that there's more neurotransmitter available. It can prevent an impulse traveling to the postsynaptic neuron, or it can mimic a neurotransmitter, and it can have an effect at an organ or tissue level. So barbiturates typically aren't used for a lot of things anymore, but typically they're used for their sedative effect. One of the reasons we don't use them much is because they do have a high risk of psychological and physiologic dependence. As you can see, they're a class 2 drug, and so they are highly controlled. Examples of barbiturates are usually pretty easy to identify because most all of our generic names for barbiturates are going to end in barbital. So we have pentobarbital, secobarbital, phenobarbital. These may be drugs that you've given in clinical that you're familiar with the names of them at least. The main differences in our barbitals is that some of them are short-acting, some of them are intermediate-acting, and then some are long-acting. As a general rule, even though we call some of them short-acting, all of our barbitals have a relatively long half-life, and so you already know what that means in terms of the staying power of the drug, And so if it has a long half-life, now you want to apply that knowledge to what does that mean for the patient taking a barbiturate. And I think you can figure out if this is used to sedate, to decrease the excitability of the nervous system, causing relaxation or sleep, then, and it has a long half-life, it's going to stay there for a long time. So daytime drowsiness is often a side effect. More importantly, though, we have to consider that our barbiturates especially don't just affect the don't just have a sedative effect. They are going to depress all nervous system function. And so an overdose can be life-threatening because it is going to cause respiratory depression. It is going to lower blood pressure. So we have to consider those things when utilizing barbiturates. So side effects typically are dose and route dependent. Obviously, the higher dose that I give, the more likely I am to have daytime drowsiness, to have impaired coordination. And also it's going to increase the risk of dependency, which barbiturates already have a high risk. So the more dosage that I give, or the longer time over which a patient receives barbiturates, the more likely they are to become psychologically and or physiologically dependent. Withdrawal from barbiturates can be life-threatening. They can be extremely severe and fatal. So so side effects, again, dose dependent. They're also route dependent. Obviously, I'm going to see side effects more quickly if I've given it IV versus PO. PO is going to take longer for the effects to kick in, has to be metabolized first, versus giving it IV, it's going to go immediately to the brain and have an effect immediately. So again, we're looking at what is the reason that we're giving it. Sometimes we use the barbitals for static epilepticus. So a patient comes in with seizure disorder and they're in the middle of a grand mal that's gone on for a long period of time. We need to stop that. So the best way to stop that is to flatten out those nerve impulses, and that's going to interrupt that seizure activity. So barbiturates are sedatives, and primarily they are given for that reason, to help a patient relax, reduce anxiety, as opposed to being used for a sleep disorder. And we're going to use them for the shortest period of time possible because of their high risk of dependency. We want to, some of the things as a nurse I need to consider when utilizing barbiturates or for my patient is that I need to monitor for sleep disorders. Because certain conditions, such as sleep apnea, if my patient has sleep apnea and I give them this sedating barbiturate, most likely their sleep apnea is going to get worse. If I sedate them too much, then I diminish their brain's ability to wake the patient when they stop breathing. And so that obviously, for obvious reasons, can have be a fatal side effect. Again, I mentioned earlier the hangover or daytime drowsiness. People taking barbiturates often have this flat affect. They look and act stoned. Their speech is slow. Their facial expressions are slow. They have impaired musculoskeletal coordination, and so safety becomes an issue. Risk of falls is going to increase. Impaired judgment certainly is a real possibility. Don't drive, don't drink alcohol. We don't want anything else that is sedating to the central nervous system when taking barbiturates, because that's just going to compound the sedating effects. Occasionally, individuals will have a paradoxical effect. You might see this in the very young or the very old. And a paradoxical effect simply means it has the opposite effect of what we intended for it to do. So instead of sedating or helping the patient relax, it stimulates them, causes them to climb the walls, and become highly anxious, as opposed to relaxing and calming them down. So we do want to watch for that paradoxical effect as well. As with any medication, hypersensitivity or allergic reaction, we're always going to watch for. And then barbiturates can cause blood dyscrasias. So we need to monitor, if they're on it for long periods of time, white cells and red cells for adequate production or changes in the morphology of those cells. So if you think about the intended or therapeutic effect and the potential side effects, from that you can glean what your nursing interventions are going to be and what am I evaluating for. So obviously for evaluation, I'm looking for a decrease in anxiety or improved ability to sleep. That would be the therapeutic evaluation that I desire. But I also need to be observing for those side effects or adverse effects. So I need to monitor for too much sedation, monitor vital signs, respiratory rate, monitor their labs, make sure they have adequate liver and kidney function prior to starting it. It already has a long half-life, so if I have liver or renal function issues, what is that going to do to the half-life of this drug? And I think you can answer that based on what you learned in Unit 1. So with each of these medications that we're going to talk about, you want to be able to apply the nursing process. So I may not give you all of that information with every drug that we talk about or every class of drugs, but you can utilize the things that you know already to figure that out. So with barbiturates, they're going to cause sedation. They sedate all nerve impulses, not just the ones that help us stay awake. And because of that, side effects go beyond drowsiness, and we can see respiratory depression, severe hypotension, the risk for hypovolemic shock. Not that they've lost fluid, but the effect on dilating, relaxing vessels gives us symptoms that would be similar to hypovolemic shock. So it can lead to death. And because it is highly dependent, then I need to be observant for those things as well. So as a nurse, what do I need to assess prior to starting these drugs? What am I looking for therapeutically, and what am I looking for adversely? And what am I going to do about those things? If I've given a patient IV phenobarbital, perhaps for a seizure. And they begin to go into respiratory arrest. I can't retrieve that. I can't take it back. So I have to know what is it, what am I going to do? So those are some of the things that you want to know. We know that safety is going to be an issue. So we need to implement those safety mechanisms. So that gives you an idea of where we're going. Benzodiazepines are another class of medication that's frequently used for anxiety disorders and for sleep disorders. With anxiety disorders, we're looking at I guess let me rephrase and say that with benzodiazepines, they're frequently considered sedatives or hypnotics. We don't always have to use a different drug. I may use the same benzodiazepine to produce relaxation or produce sleep or to reduce anxiety. So it may not always be a different drug. It may simply be a different dose. So a low dose of a benzodiazepine would act as a sedative, whereas a higher dose may act as a hypnotic and actually put the patient to sleep. Long-term usage could alleviate anxiety over a period of time. So you see that the benzos typically are used to treat insomnia, decrease anxiety, or maybe help with relaxation prior to a diagnostic or going into the OR. Most of your sedative hypnotics, such as benzos, increase total sleep time, but they can affect REM. Now, what is REM? This is your rapid eye movement. What does that mean for my patient? What happens during REM sleep that makes it important for me to know? So one of the things that you have to do, because I'm not going to cover it, is go back and refresh your memory on the sleep cycle. What does REM sleep do for us, and how does shortening the amount of time the patient spends in REM sleep adversely affect them? So use your detective skills. You know, when we're using these drugs to treat anxiety, keep in mind that most patients realize that their responses or their feelings are out of proportion with whatever is occurring. It doesn't matter. They're unable to control that, and that's what we're helping them do, is to try to control some of those. So anxiety disorders can include panic disorders, phobias, obsessive compulsive, as well as generalized anxiety. So the benzos, again, can be used for all of those things. They inhibit let me take that back. They don't inhibit GABA. They enhance GABA. Now, what is GABA? GABA is gamma aminobutyric acid. You're probably saying, what the hell does that mean to me? I don't know any more than I did before. Well, GABA is a naturally occurring inhibitory neurotransmitter. So what does that mean? Why do you care? Because it's an inhibitory neurotransmitter, it prevents overstimulation of the nerve cells of the central nervous system. So when I bind with that GABA receptor, that's the same thing as turning that GABA receptor on. And so I can use that to cause the patient to become calm or more relaxed. So naturally, GABA keeps us from constantly pinging off the walls, if you will. But as with all types of central nervous system mood disorders, there's often some type of malfunction with these neurotransmitters or their receptors, and so we give benzos to bind with that GABA receptor and tell the brain that, hey, you have plenty of GABA, you can calm down now. So by binding with GABA, we increase the central nervous system depressing effects. Again, it can be used for sleep or anxiety. It can cause physical and psychological dependence, and long-term use of benzos can cause withdrawal symptoms to occur, and not as life-threatening as with the barbiturates. However, it does occur, so I need to be aware of that. Most of your benzodiazepines have as side effects, besides sedation, blood dyscrasias. Again, I'm going to watch for that, those white cells and red cells if I'm using it long term, and hepatotoxicity. Because it can cause hepatotoxicity, what does that mean for as an assessment prior to initiating benzos? Obviously, it means I need to make sure that my patient doesn't have liver disease before I even start. A lot of the benzos have a long half-life and active metabolites. So again, think to yourself, what does that mean? Well, you can figure out long half-life. We've just talked about that with the barbiturates. But with the active metabolites, what does that mean? Well, it means it goes through the liver and it's metabolized into a more active form. And so then these circulate, and not only does that prolong the half-life, but it's going to, which in turn means that the drug is going to be more active for a longer period of time. Usually benzos are going to take about a week for optimum response. And you have to ask yourself, what is the response that I'm looking for? It's going to be somewhat dependent on why am I giving it. If it's being given for sleep, then is my patient sleeping better? If it's given for anxiety, do they have decreased anxiety? Do they verbalize an increased ability to cope? What is it that I'm seeing that says, hey, this drug is working for my patient? Probably the two most commonly used benzos would be oxazepam and lorazepam, simply because they do not have the active metabolites, so they're not going to last as long. So I wanted to put this in here because one of the things I encourage you to do is to categorize your medications. And so just like with the barbiturates, most of them are going to end in barbital. Most of my benzodiazepines are going to end in PAM or LAM. So therefore, hopefully this helps you remember a little bit about how to recognize this, whether it's on a unit exam or whether it's on NCLEX or whether it's a new order that you just received from your healthcare provider. So if it ends in PAM or LAM, it's probably a benzo, and benzos are used for sleeping or anxiety. So Flurazepam, Triazolam, or LAM, Lorazepam, all of those are benzos and that helps you to keep in mind what it is that we are using them for, and what we expect to find. Now, I'm not going to go through every single side effect or nursing intervention. A lot of them are, what do I want to say, common sense, I guess. You can figure them out. If I'm giving my patient a sedative, something that's going to cause them to be drowsy, then safety is obviously an issue. But again, there are some things that might not be as obvious, such as when we talked about the barbiturates, we mentioned sleep apnea. Well, maybe the patient hasn't had symptoms of sleep apnea. They don't know they have it. So an assessment might be, do you snore? They don't snore, but they started taking these and now they snore. Is that a problem? It could be. It could be that we're depressing them so much they're having difficulty with their breathing. So I need to check for those kind of things. Liver toxicity is an issue. Then I need to be educating my patient. What is it they need to look for? Patient education is a big deal with your medications. It's not just about what you are going to observe in the acute care or long-term care facility, or in the home care situation, but what does my patient need to know? If they don't know that it's a problem, then they aren't necessarily going to report it. They may just assume that it's okay because nobody told them otherwise. One of the things that we want to make sure that our patients understand is that this is not a drug that's okay to double up on. They don't want to abruptly discontinue because it could cause withdrawal symptoms. And if they do discontinue it, especially abruptly, that they can experience rebound anxiety and sleeplessness, and possibly worse than what they were experiencing prior to. So as you're reading about these drugs, those are the things that you want to pick out. What does it mean to me as a nurse? And when I'm thinking about what does that mean, what do I need to know therapeutically? What stands out about this drug regarding side effects or adverse effects? What can I figure out based on what the drug does, and what is so far out there, like blood dyscrasias, that I need to just memorize that. And then lastly, about benzos, shouldn't typically be used by pregnant or breastfeeding moms, and shouldn't be used if they are pregnant or shoot, I already said that, if they have liver or renal disease. Sorry. Sometimes my brain doesn't catch up with my mouth, or my mouth doesn't catch up with my brain. I'm not really sure what's happening there. Alright, so moving on. So we also have a class of drugs called non-benzodiazepines and non-barbiturates. They stimulate the same receptors as the benzodiazepines, but they typically have fewer side effects. And the benefit to these, such as zolpidem, Lunesta, I'm not even going to try to pretend like I can pronounce that, eszopiclone or whatever it is. So those of you that work in pharmacies are probably laughing at me right now, but anyway, that's okay, I can take it. Anyway, so they are not quite as sedating. They don't have the long-term effects that the benzos and barbiturates do. They also have the advantage of preserving deep sleep. So they're not as interruptive of the REM cycle, which is very important if it's something that needs to be used for a long-term basis. So again, find out what is going to happen if REM is disrupted. Antihistamines are also a class of drug that can be used for sleep. We all know people who use Benadryl or diphenhydramine on a routine basis to help them sleep. Another antihistamine that we're going to talk about later is Vistaril or hydroxyzine. And these are antihistamines, and they, because of their anticholinergic side effects, do cause drowsiness. The biggest problem with these is that we can build up tolerance to the sedating effects of antihistamines. You know, a lot of people say, "Oh, I don't like to take Benadryl because it makes me sleepy," and that's true. It does. That's a side effect of a antihistamine. But over a period of time, that sedating effect goes away. So antihistamines are best used for 2 or 3 days. Afterwards, we can tend to start seeing a more paradoxical effect. Children especially, and again the elderly, have a tendency to have more of a paradoxical effect. A lot of people don't tolerate the dry mouth, but again, that's something that we can build a tolerance to, and it doesn't have to bother us forever. Melatonin is something that our body produces naturally in response to the dark. And so if, especially people who work shifts, who sometimes have to sleep in the daytime, find that melatonin, which you can get over the counter, helps to just increase the level of melatonin and help us relax and get to sleep. It doesn't have side effects that the benzos and barbiturates do, and it's relatively unconcerning to use. Valerian is an herbal product that does have some sedative properties, and so these, again, we want to question patients. You know, if we're giving these drugs for helping them to sleep, what else are they taking? We want to include those over-the-counter and those herbal products, and not just assume that they're going to tell us those things, because they don't consider them drugs, and they don't consider that they would interact with anything else. So we certainly need to ask. The azasparones, such as buspirone or buspar, typically used for anxiety. It is not a controlled substance because it has minimal potential for abuse, even though it is considered a sedative or a central nervous system depressant to some extent. It has a very low sedating effect, so not so useful for sleep, but yet very useful for anxiety. It also does not have the psychomotor effects that we see with barbiturates or benzodiazepines. It isn't related to those drugs, and it doesn't affect GABA. So what we do know about it, how it works, is that it has some benefit to serotonin and dopamine, both of which, especially serotonin, are neurotransmitters that help to affect our mood. Serious side effects of Buspar or Buspirone, slurred speech and dizziness, sedation, typically related to excessive dosing. So if we're seeing these side effects, it's probably because the dose is too big and it needs to be backed off. It can take up to a week to 10 days to see a response, and 3 to 4 weeks for optimal response. And again, if you think about why are we giving it, we're giving it primarily to reduce anxiety. Then we're going to think about what is my therapeutic effect, and we hope that the patient will verbalize decreased anxiety and or improved coping skills or improved coping ability. Now, we talked about, or I mentioned hydroxyzine earlier because it is an antihistamine. That is its classification, but it has multiple uses. It decreases anxiety. It can decrease the need for excessive anesthesia during OR. It can reduce vomiting, and it can be used for itching. So it has multiple uses. But also, if you think about its classification, it is an antihistamine. That's going to help you determine some of the potential side effects. So sedation, dry mouth, constipation, blurred vision, these are all typical side effects of antihistamines because most of our antihistamines produce anticholinergic effects. So think about these side effects and what would I do about that if my patient's taking hydroxyzine for a long period of time to reduce anxiety. And they're more than likely going to see some of these side effects. What do I want to do? These are the kind of things that we're going to ask on test questions for these medications. So it isn't enough just to know, I don't want you to just memorize its action, or I don't want you to just memorize what it's used for. I need you to understand the consequences and the therapeutic consequences of these meds so that you can answer the questions appropriately. Signs of overdose typically, again, are going to be slurred speech and dizziness, and that just says we need to back off. It does interact some with other central nervous system depressants, so not a good idea to ever take an antihistamine with alcohol or with a barbiturate or with even an opioid or anything else. Not so much because it's going to accentuate those sedating effects and could possibly increase the risk of respiratory depression or even just having the patient be knocked out. So safety becomes an issue.